So we're going to do all of it. IV fluids, blood, PN, IVP, CVAD. Okay, this is review. Oops. This is normal physiology. Remember I told you there's those required lectures in the course? They cover this material. Again, I'm just doing the lecture because of my OCD and I want it to, I don't know. But so there are 3 different lectures. There is a lecture on this, the IV fluids. It's about 8 minutes long. So I'm going to go through this kind of quick, but I wanted it there for anyone who wanted a review. So basically, normal physiology for fluids, they maintain homeostasis, right? They transport nutrients, electrolytes, and there are very narrow limits of normal. There's fluid inside the cell, intracellular, and there's fluid outside the cell, extracellular. So that's pretty much sums that one up. All right. So there's a lot written on this page. Stop, take a breath, focus for just a minute. This is all review from what you have. If you need to review this, go back to this slide in the lecture and write it down. If you got it, you got it. But it's important to understand some basic concepts for when you're giving fluids. Because you can memorize what fluid to give when, but you're going to get in a test situation and you're going to freak out and you're going to go, I can't remember if it was half normal or quarter normal. But you can figure it out based on why we give it, okay? So these are all different ways that we use, right? So you have diffusion. This is where molecules move from high to low concentration. So this picture up here, right? They move, there's a lot of molecules here, and they're moving to low. And it can be simple, where it just happens and no energy is required, or it can be facilitated, like where they use glucose. So we purposely, so that's why we have fluids that have dextrose in it, because we purposely want to pull fluid or pull molecules over, okay? There's active transport, where basically they have molecules move against it. So active is different than diffusion, they're opposites. It moves from the low area here over, right? You have osmosis, which is the movement of water. So it's not molecules, it's water that's being moved. And typically, you go from a less concentrated but high O2 to a more concentrated, less H2O. Bleh. And there's no energy required. So that gets confusing, right? So it's movement of water. And you have an area that's less concentrated. So a fewer amount of molecules, but a lot of water. And they move to an area that has a lot of molecules, but not a lot of water, right? Does that make sense? It's kind of opposite. You had the osmotic pressure, which is that pressure required to stop osmosis. You have hydrostatic pressure, and you have oncotic pressure, which is going to be important when we talk about things like albumin. And that's the pressure that causes the colloids to pull fluid from that space. So these are all terms that you should know, that, God bless you, that you should have, that if you're a little vague on, I would review, okay? Because any of these, anything that changes, if you change the diffusion, if you change the oncotic pressure, it's going to help. It may either cause edema or dehydration or help edema and dehydration. Again, this is a lot of review on this slide, so I don't want you to... These are all things that regulate water, okay? Again, if you want to go and talk about the RAS system and the hypothalamic pituitary regulation, GI regulation is things like diarrhea, vomiting. These are all the different ways fluid shifts in our body. Remember, there's very narrow windows. If you need a review, I would look into it. But there's insensible water loss. Like I said, diarrhea, vomiting can cause it, cardiac regulation, all these things causes the difference in balances, and that's why they need fluids. So fluid and electrolyte imbalances, they're classified as deficits or excesses. And it's a direct cause by some kind of illness or disease. So a burn, there's a massive fluid shift. Heart failure. And they can be a result of therapeutic measures. So sometimes we're treating them and we give them IV fluid or we give them diuretics and we cause the fluid excess or the fluid deficit. So it's always some kind of deficit or excess, and it's either caused by some kind of illness or disease, or we do it. Whoops. Why do we give fluids? I wouldn't write everything on this slide. We're going to go over it on each individual. These are going to be individual, isotonic, hypotonic, and hyper. They're going to be individual slides, have the same writing. I wouldn't write it twice unless you really want to. The purpose of it is either maintenance or replacement. They're not taking enough fluid, so we have to give it to them, or they have some kind of deficit and we need to give it to them. And there's 3 different types. They're categorized by their tonicity. So they're either isotonic. So the fluids have the same osmolality. I always have a hard time with that word. Hypotonic, they're less, hyper, more. So hypotonic. Again, so this is where a solution, where the solutes are less concentrated than the cells. So there's more water than electrolytes in a hypotonic solution. Here's my pretty picture. So the blue is obviously water. The red is electrolytes or molecules. You'll see me kind of use those interchangeably. So you have, that's the cell, the circle, the bigger black circle. That's the cell. Inside the cell you have a lot of molecules and a little bit of water. You give them a solution, the stuff outside the cell, with a lot of water and a little bit of molecules. This is why we have to understand how osmosis and how those work, because what are we doing here? Why do we use this solution? What? To hydrate, right? Because what principle are we using? All right, we have diffusion, active transport, osmosis. So with osmosis, what's happening? Water's moving from a less concentrated area to a more concentrated area, right? So for osmosis, we have this less concentrated area outside the cell to a more concentrated area, because we want them equal, right? So we got to move water in to make the ratio equal here. So if we're using a hypotonic solution to move water into the cells, it's because the cells need to be rehydrated. So they move from an extracellular to intracellular by osmosis. And we said it's used because we want to either maintain fluid or they need to be hydrated. We want to hydrate those cells. But you have to be careful, right? Because if we're taking a bunch of water and we don't be careful, if we give them a ton of hypotonic solution and we're pushing all this fluid into the cells, what can happen to the cell? It's going to swell, right? So things like cerebral edema can happen because you have all this cellular swelling. So if they have cerebral edema happening because you're giving them too many hypotonic solutions, what clinical manifestations are you going to see? It's on the board. Change in mentation. Yeah. Right? So, am I going to tell you your patient has cerebral edema because of too much hypotonic fluid? No, because again, what is our goal as nurses? To make our patients not die, right? So, or make them not hurt. So if I walk into my room and my patient's receiving a hypotonic solution, and I'm like, oh, okay, they're on this hypotonic solution, and this morning they knew their name and everything else, and now they don't. That's a change in mentation. Am I worried about cerebral edema? Am I going to call the physician and say, hey, I may need you to cut the fluids in half or stop the fluids because I'm concerned? All right? That's how we use this. So that's why it's important to understand how the mechanisms work and why we're giving the fluids that we give them and what can happen with them. So examples are half normal saline and normal saline. So it's the way it give me a second and I will get into that. One of them, and I'm going to double check so make sure I tell you the right thing. One of them is ISO outside the body, but when it gets in the body, it's D5. Okay. Okay. I will look it up and tell you, but I can tell you this is it. We'll discuss it. Make me a note and we'll discuss it. I'll come back to it. In fact, I can write myself. All right. So isotonic is where everything is equal, right? What was your question?
This semester we were taught as isotonic.
Normal saline? Mm-hmm. Okay.
Yeah, on this paper it says ISO.
Okay. Well, I will double check that and make sure that, and if that's what you're taught, then it could have been my mistake. I will double check it though. I don't want to confirm it because if I have it written, I had it written for a reason, but I will make sure I give you the right info, okay? But I would say that half normal saline, 0.45. Go with that. Okay? All right. And I will check on normal saline. So isotonic, that's where everything is the same. So if everything's the same, are we going to have osmosis happening? No. All right? So you have the same number of molecules on the inside and out, and you have the same number of water molecules on the inside and out. So if we're not having any shift in fluids, what's expanding? Where's your fluid expanding? Inside or outside the cell? Outside the cell, right? Because there's no osmosis happening. So an isotonic fluid, everything's the same, inside and outside the cell. So when I give that fluid, it's not like a hypotonic where I gave that fluid and I pushed that fluid into the cell. This, I'm giving the fluid and it's just sitting outside the cells. No effect on the intracellular. So if we are giving a hypotonic solution because we're dehydrated and we're pushing fluid into the cells, why are we going to give an isotonic? So the fluid outside the cells are fine. I'm not dehydrated, but the the fluid outside. Huh? Not. It could be maintenance, but what? Hypovolemia, yes. There's a fluid deficit. So we're not dehydrated. The cells are hydrated, but I lost a bunch of fluid because of blood. I was in a car accident. I got something cut off. Because we need to expand that volume real fast. I don't need to worry about the cells. The cells are hydrated, but the volume inside me is not. And I'm going to double check this, okay? Because I have it normal saline here. So don't worry about the normal saline. But, yeah, LR and D5. So normal saline, that's the only fluid. The big thing with that is that's a really good fluid to know because it's the only fluid we can use with what? Somebody said blood. Yep. I know we don't give, you guys don't give blood, but you will as nurses. And it's the only one that's compatible with blood. Is normal saline. Yeah. So isotonic solutions are your LR and your D5W. And again, they're used for things for like burns, GI losses, things where you have a big fluid shift, right? And you have that loss of fluid. You have a volume deficit. Your cells are hydrated, but you've lost volume. And I wouldn't worry too much about writing everything under LR or everything under D5W. I would understand that those are your isotonic fluids and they're used for the fluid volume deficit. All right, so hypertonic, that's where the solutes that we're giving, or the solution that we're giving them, has more solutes than what's in the cell itself. So there's more electrolytes than water. So how does osmosis work? Uh-huh. So where is fluid going to move in here? From the cell out, right? So if I'm trying to move cell or fluid outside the cell. Why would we want to maybe move fluid outside the cell? Yeah. So if I have a bunch of molecules, what are those molecules? Electrolytes? What are some of your electrolytes? Potassium, sodium, right? Do we have some instances where we might have high potassium, high sodium? Well, typically it's high sodium because potassium is typically inside the cell. But high sodium, and let's say your patient's is super hypernatremic, and they're going to have, how do we make sure we're going to pull some fluid out of the cells? Because we're going to cause a dilutional hyponatremia. Does that make sense to everyone? Or did I lose? Tell me if I lost. Did you need some?
Repeat it.
Okay, that's okay. So I'll use this since I have it. So let's say that all these red, right, are sodium. And I want to move, right now, at this sodium level, it's 150. Okay? I'm now going to move all these little blue dots out here. Now technically my sodium's 130. Did my sodium change? Or did I just add more water? I diluted it. So that's that dilutional, right? So we're pushing the fluid out to kind of dilute it. So when we have electrolyte imbalances, or sometimes, ooh, I went crazy. Oh. when we have some electrolyte imbalances or we are hypovolemic, we can take some of the fluid that's in that cell and move it out. So if we're taking a lot of fluid outside the cell and moving it into the vascular space, what can we do to them? Before we were causing cerebral edema because we're pushing all this fluid into a cell. Well, it's still in the vascular space. It's just not in the cell. It's in the vascular space. So if you have too much fluid, they get what? Wet. Like, yeah, I heard it a couple. They get wet, right? So what are some signs that they're wet? Crackles. What else? Edema. They can get some fluid overload, right? So if we're giving too much of that, we have to be careful. So they really need frequent monitoring because how do we monitor fluid overload? Weight, blood pressure, lung sounds. Again, don't worry because this is just more in detail. But the examples are D5.5, normal, and D10. It is important to know, so D10 is what? Dextrose, right? And that can be very hard on the veins. So you do have to be careful. Once you get greater than 10%, if you do like D20, which you guys shouldn't do a lot except for, but if you do something any more than D10, you do need a central line, which will be a nice like segue into our next topic or topic coming up. All right. So does that make sense to everyone why we use the fluids we use? And why all that stuff you learned, I think, in level 2 actually meant something? Any questions about that stuff? I will check on the normal saline for you all. But I honestly don't think it's going to make or break anything else. But I will check on it so I give you the right info. All right. So sometimes we use plasma expanders. So they stay in the vascular space and help that osmotic pressure. They're typically a protein solution. The big one that everybody knows is what? Albumin. Yeah. I think. There's 5%, which is the same as plasma. And it's really good to treat hypovolemia. There's 25%. And this solution is very hypertonic, hyperosmolar. So it basically draws all this additional fluid from the IS and pulls it extravascular to intravascular. And it's used for a volume expander, and it helps with edema. So if you have a patient that has a large amount of edema, we can give albumin. It's going to pull tissue from, because remember you have cell, right? Let me see. I'll use this. So remember you have the cell itself, the vein, right? And you have this space outside that's like your tissue. Okay, and you've got fluid in all those areas. So it helps pull space from like the tissues into the vascular space. Because it's super hypertonic, super hyperosmolar. And yes, things like volume and edema, it's really used. The other colloid solutions are things like dextran, head of starch, but The one that you guys are going to see a lot and we're going to talk about is the albumin. Okay. So again, your module has a whole thing on blood. There is the, if you need it and it helps you study, your module has the table to distinguish between those fluids. And I would talk yourself through it why you're going to give the fluid that you're giving. So that's going to be easier to remember than trying to memorize and then forgetting once you freak out in a test. Because I would, when you get to a test, take all this information and brain dump it onto your papers. And then if you get to a question that you're like, I can't remember, go back to your brain dump and go, okay, that works, this. Okay, now I see what I've got, okay? So there, it looks like it's page 7 that it starts for blood. It's got your little thing, your little paper. But the blood is made up of plasma, white blood cells, platelets, and RBCs. Don't freak out or write all this down. The big thing to remember, there's different types. Everyone knows the types, right? I hope we all do by this point in nursing school. A, B, AB plus, O negative. Sometimes people get confused on who can donate and who can receive. The thing I would say is that pluses can get everything because pluses include a negative. Does that make sense? Mm-hmm. Okay. So if you have a plus positive blood type, it has, what is a plus made out of? It's a negative sign plus, right? So it can receive all the negatives plus all the pluses. Negatives can only receive negatives. They can't receive positives, right? All right. So if you need something, kind of an easy way to remember, I would use that. But O negative can go to everybody, right? Because it's a negative, so it can go to everybody. AB positive can get from everybody because it has A, it has B, it has negative, it has plus. Does that make sense? All right, if it doesn't, tell me. Okay. All right. So if it's made, blood is made of different things, why are the different reasons we give it? So, red blood cells, so you'll see it come like this. It's labeled A or B or AB. It's got the RH factor, so whether it's negative or positive. There's some different ones. Here's one that's B. So it's all labeled. It's used for any surgical or trauma loss, anemia, and it replaces volume in O2, right? Because it carries oxygen, helps with anemia. You always, like I said, do with normal saline, and they'll show you this in the packet, but this is special blood tubing that you use. You hook up normal saline to one side, blood to the other. You prime it with the normal saline, and then you're going to run the blood. You guys won't be doing this again, right? You all will never hang blood as a nursing student. But as a nurse, you will. And as a nursing student, you can monitor them. So once the blood is hung, is that the right word? Yeah, hung, then you can monitor them and do the vital signs and everything. So this is what you'll see. Platelets are for thrombocytopenia.
Excuse me.
Yes.
What is that? What it says above replaces volume?
Bone marrow failure. Oh. Sorry. Not a BM. So platelets. Is this supposed to be my platelets? Yes. So often you'll see platelets, clear fluid. They're often in a syringe. Sometimes they're in a bag. But obviously if their platelets are low, we give them platelets. And DIC, you'll learn more about DIC and why platelets are important in test 3. FFP, this is when you have low clotting factors. It looks like Sunny D, doesn't it? So it typically comes in a bag too. It's bright yellow. You see it's much brighter than your platelets. And so when you have low clotting factors, that's when you're going to give FFP. Which one?
What was DIC? I'm sorry.
Which one?
DIC, what is that?
DIC, it's disseminated intravascular clotting, something like that. Oh God, I should know, I lecture on it. I always just call it DIC. It's a disease process. We're going to talk about it in test 3 more in depth, but it's basically you're clotting and bleeding at the same time. So your platelets are really low, so you need platelets. So obviously platelets low, you give platelets. If you're not clotting, FFP. If you have the need for volume replacement, blood, whole blood. So how do we prepare it? Always verify the order. How many nurses do you need? 2. Yes. You need consent from the patient. That's important. You need to make sure consent's on the chart. You're going to try to use an 18 gauge IV if you can. Obviously, sometimes we can't get that, but you're going to take a set of initial vital signs. And like I said, you're going to prime your tubing with the Y tubing. Only using normal saline.
Is there an ideal IV location placement?
No, wherever you, a lot of times, well, in an emergent situation, doesn't matter. Wherever you can shove it is going to be good. That sounded mean, but I didn't mean it mean. Sometimes the ER nurse in me comes out. I'm sorry. But does somebody have a question? No. Okay. All right. So now we're going to administer. We've prepped it. Now we're going to administer it. We have to hang it within 30 minutes. The cells start breaking down, right? So if it's sitting there for a long time, that's why it has to be administered within 4 hours, because everything inside that blood starts breaking down. We're going to talk about what happens then. You have 2 nurses who verify that it's the correct blood, that it's the correct RH factor. Then you compare the number. It will always have a number on there. Can everyone see? That number should match what's ordered, should match the patient's ID band. They take it very seriously because they can have bad reactions. So you're going to make sure all that is done. Don't freak out about memorizing the initial rate. You started off slow for the first 15 minutes. Why? Reactions, right? We just want to make sure we don't kill our patient by flooding them. So if they're going to have a reaction, they're probably going to have it pretty darn quick. So we started off slow and then we can increase it. We don't want to exceed 4 hours for a unit.
After the 15 minutes, what does that say? Over 2?
Remainder over 2 hours. Sorry, you'll get used to my shorthand, I promise. My hand feels as bad as yours after I'm done doing these. At least I can say I sympathize and empathize your pain. I don't make you do anything I haven't done myself. And then you're going to do vital signs per policy. Typically it's every 15 minutes, but always do it by policy. All right, so you're going to monitor for any reactions. All right, so again, what do we use blood for? Volume expander, right? Yeah. So if we're volume expanding, again, just like when we talked about isotonic solutions, If we're going to volume expand, what is the patient at risk for? Volume overload. Good. So if they're at risk for volume overload, we're going to be making sure that how do we monitor for signs of reaction?
Crackles, long sounds.
Exactly. Crackles, lung sounds. Plus they could have other reactions like, they get hives, they break out. The classic reactions that people think about when they think of a blood reaction. If there's shortness of breath, that could be a sign of fluid overload too. So once we're done, we take all of it, and where does it go? Red bag, right? Red bag. Red. Anyone listen to country? No. And then we're going to document how much the patient received, the patient reaction, the duration. What happens if you walk in the room and it's been 4 hours? I hope you would never do this and only half's gone in and the whole thing was supposed to go in. Are you going to give it another 2 hours to put the rest in? No, it's done. So that's why we kind of keep an eye on it, because it does expire. All right, don't freak too much about this slide. There you go. Your reactions can be either acute or delayed. They can be mild, like an allergic reaction, just a mild non-hemolytic, or they maybe get like a little fever. What are things we can do? Tylenol, right? Maybe they get a little hive, but they don't have any respiratory issues. What could we give them? Yeah. So typically, if the patient has received blood before, and they'll tell you, I break out in hives. Sometimes they complain of red man syndrome or different things. We can pre-medicate them and help treat. It doesn't mean that they're allergic to the blood. It doesn't mean that they can't receive the blood. It just means that we may need to treat them prior to them getting the blood with the right medicines. We talked about the circulatory overload. They can get septic. They can have, like we talked about, allergic anaphylactic when they get like the short of breath or really itchy. Or it can be delayed, which is 3 or 10 days later. They get either too much iron from the blood. They can develop hepatitis B or C.
What was the last one under acute?
It is TRALI, and it's T, capital T, lowercase r-a, capital L, capital I, and it's an acronym, and I can't tell you what it stands for. I can look it up for you if you want, but it won't be.
Is it on the test?
I can't tell you what's on or on the test. I just wouldn't maybe spend a lot of focus. All right. So one of the ones we talked about was the acute hemolytic. They often get, this is one of the most common ones. Common reactions. They get fever, hypotensive, nausea, vomiting. And we talked about this already. We can treat some of these by pre-medicating. Other serious reaction that we see is a massive blood transfusion reaction. And this, where the replacement of blood exceeds the total blood volume within 24 hours. And some of the complications, and again, this is why we don't let bags sit for longer than 4 hours, and why we be careful, because there's red blood cells, right? What's inside a red blood cell? What electrolyte? potassium.
Yes.
Okay? So if potassium's inside that red blood cell, and as time goes on, those red blood cells are breaking down, what's going to happen to that potassium? It leaks out, right? So what's going to happen to your potassium level? It's going to shoot up. So, and Miss Lewis is going to talk about this when we talk about test 2. You got to be worried. So if they get hyperkalemic, what's going to happen to their rhythm, their heart rhythm? They're going to have dysrhythmias, right? So if all of a sudden you're giving your patient blood and they're saying, I feel funny, my heart's beating, would you be a little concerned? Yeah. Again, because they're not going to tell you, my blood transfusion has been quite some time and the red blood cells are leaking potassium and I think I might be at risk for a heart rhythm. We want you guys to figure that out, okay? All right, the citrate, we give citrate, it's added to stored blood because it binds to calcium. So if it binds too much and we're giving blood and it binds all the calcium, what's going to happen to our calcium levels? And they're going to plummet. And again, we talked about the arrhythmias because of the hyperkalemia. They can also get hypothermic. All right. So what do we do if our patients are having any kind of reactions? Stop the transfusion. Do not pass go. Do not collect $200. My husband had a ruptured appendix, and he was having a reaction to the it wasn't blood, but it was to the medicine. And the nurse said, well, I'm going to call the doc and see what I should do. And I was like, you're going to turn off the med. That's what you're going to do. And she said, well, I need to get the order from the doc. She walked out the room. I just stopped it and took it off of him. So you don't wait to hear back from the doctor to say your patient's having a reaction, because the reaction is going to keep happening until you stop what's causing it. So you're going to stop the transfusion, but you're going to stop the blood, but you're going to keep maintaining the normal saline, okay? So whether you hang a different bag or you clamp off, because oftentimes they have its own, so you clamp off the blood portion and you just have your normal saline going. Then you notify the physician, and you're going to send all of this where? Do you throw this away? No. Where do you send it? To the lab, okay? They're going to test it to see if there's anything funky in it. While this is all happening, I know I have it as 5 and 6, but while this is going to kind of happen quickly. You're going to stop it, stop the blood, have the normal saline going, call the physician, and tell someone to send this to the lab. That's all going to happen pretty quickly. But while you're doing that, you're going to be taking vital signs, documenting documenting what you see, what kind of reaction they had. Huh? Urinary output. All right. Any questions about blood? I know it's a long day, y'all. We're getting through it, though. All right. So PN, what is the goal? We want to meet the nutritional needs and allow growth of new body tissue. So we give this when nutrients from some other route aren't enough. So we give nutrients by route other than the GI tract. So, for example, by bloodstream. So we can't give it GI for whatever reason, so we have to give it through the bloodstream. It's always prepared by a pharmacist. And I wish we had it better. Oh, God, I cannot bend over. I don't like this example because you need the thing that has the... So it will come and it's yellowish like this, but it comes with like a giant sticker. It's a giant big sticker that has 400,000 things that are in it, okay? Because it's got, I mean, it's electrolytes and fat and all this other stuff. You have to do it aseptically. It's kept refrigerated until about 30 minutes prior to use. And again, 2 nurses need to check. So typically the pharmacist will send it to you just before you need to use it. Mm-hmm.
This might be a really stupid question. But
Never stupid.
So when the pharmacist makes the TPN, do they have like, here's a bottle of like protein?
I don't know.
And they go,
I honestly don't know. I have no idea. I'm assuming that they have bottles of potassium and bottles of sodium and bottles of whatever, and they draw it up and make it based on that. But how exactly it's made, I've never seen it, to tell you the truth. It's different for every single patient. So typically what will happen is the docs will round in the morning, and Miss Lewis, tell me if it's different than you've seen. They'll round in the morning, because I haven't had to give this in a long time, because I did ICU for a bit, but now I've done ER for the last like 10 years. They'll round in the morning and they'll say, this is what this patient needs. And the doc, which is sometimes the resident, so it's super scary, so check, especially if it's July. So when the brand new residents come out in July. So they'll write down, and there's a piece of paper, and it has everything written. They want potassium, sodium, this and this and this. And the doc will write down what they want in it. That is an order that gets sent to pharmacy. Pharmacy gets that order and then fills it and says they wanted 2 of potassium, 3 of sodium. I mean, I'm just making up numbers. But they fill up the solution. It's actually used the next day. Because what they're on, like what they're on right now, is what the doc wrote for the day before. So then they get lab work all throughout the day, and then they base it, and then they hang it. So they're making subtle changes. Sometimes it stays the same the whole time, and the doc will take the old one and just change the date at the top. Now, and this was before, I'm dating myself, before electronic records. So it might be a little bit different with electronic records. I think it's basically the same paper on electronic record form, and they can just like reorder it. But that's how exactly they do it. I don't know. I've never seen it made. It just always comes to me.
or is it all just the
No. I just don't have an answer for you. I think they're good questions. I think it's beyond what you need to know, but it's not a bad question. I just don't know the answer to it. I can find out though if you want me to. Okay. All right. I will never pretend that I know something up here. Not everybody knows everything, so if I don't know, I'll be the first to admit it, and I'm always happy to go look it up for you guys, okay? All right, they're hypertonic solutions, right? Because they have a bunch of molecules in fluid. So obviously, the PPN, peripheral, is peripheral inserted. Imagine that. It's used short term. Typically, the protein and calorie requirements for this patient aren't very high. They just need a little bit, a little extra help. They may be on it because the risk of a central catheter is too high. And sometimes the patient is able to eat, but they're just not eating enough. So we give them a little TPN to kind of help things along. And we don't need to put a whole central line in. Yes?
It says peripheral, but that's still at least a pick, right? You wouldn't give that through.
Yeah, typically it's a pick. And we're going to get to picks and central lines in just a second. This all kind of leads to that, I promise. And the glucose has to be less than 20%, right? Because anything higher, we require that central line. Typically, anything greater than 10%, which a pick is considered a central line. But for peripheral inserted, it's less than 20%. And I will, when we get to that point, remind me and I'll explain that better. But I don't want to do it until we're with it. All right, so central, which is TPN, which is what most of you have heard of. It's centrally inserted. It can handle glucose greater than 20%. That's a big difference. And so with a central line, and we're going to get to it, but let me draw it here. It lays in the superior vena cava, and it's for long-term support. So I'm going to go back on this slide just a second. No one freak out on me. All right. So when you're looking at, like, the heart, you have the inferior vena cava right here, right? I'm sorry, superior and inferior vena cava here. All right. So what they'll do is they will take this catheter, and I'm going to get to it more. They'll take the catheter, and either they're going to centrally put it in, or what was your name again? I'm sorry? Jeff was talking about peripheral, which is a pick. They'll peripherally insert it, and they'll insert it into like your arm, and they thread it all the way up, and they thread it into that superior vena cava, and it sits in this right atrium of the heart. Okay? So when we're talking about like peripheral IVs, it's still peripheral, right? Because we're still putting it in right here. A peripheral IV can only withstand about 10%. A PIC is it's a central catheter because it goes to the heart, but it's peripherally inserted. Does that make sense? They can withstand like 20. When we talk about central catheters, which I'm going to get to, they do like greater than 20. All right, so why do we use PN? I'm not going to spend a whole lot of time on this. Basically, all the reasons, because they can't get enough nutrition. They have intractable diarrhea, vomiting. They had a really complicated surgery. They have a GI obstruction. They're malnourished, or they have really high nutritional needs. They maybe have a malabsorption syndrome, meaning that they do eat, but nothing gets absorbed. So what's all this stuff inside of it? Inside PN. So this is labeled TPN, but remember TPN is PN, right? Because it can either be peripheral or centrally. So inside of this are some carbs, right? Typically 20 to 50% dextrose. Fats. You have all sorts of protein, amino acids. I wouldn't freak too much about numbers. You have all the electrolytes, sodium, potassium, chloride, magnesium, phosphorus, calcium. And then you have a bunch of trace elements: zinc, copper, chromium, mag, selenium, iodine. So that's why all of these are listed on the bag and how much the patient is getting. And then so you're going to take that order with those 30 things, or it just seems like a dot, and you're going to sit there and compare. Yep, to make sure that it's the right. But it's got a lot of dextrose in the, because that's the form of carbs that they can get. So we're giving them a lot of sugar. So what are some complications? This is our job, right? We give it to them, and then we got to make sure that they do okay. So there can be mechanical issues, problems, or basically inserted wrong. And we're going to talk about that. The line becomes dislodged. They get thrombosis. They get irritation of the vein. Maybe we didn't realize they were getting, maybe the pharmacy put 30%, we didn't check, and we're using a peripheral inserted IV that can only do 20%. So they can irritate that vein. But more often, we see these metabolic problems, right? We're giving them a bunch of stuff. So if we give them 20 to 30% of dextrose, what can happen to their sugars? It goes up, right? So we're giving them all this sugar. If we're worried about hypoglycemia, how can we as a nurse know that they're hyperglycemia? What are some clinical manifestations? Frequent urination, thirst, sweating. So are we going to say your patient has hyperglycemia secondary to their TPN? No, we're going to say your patient who has recently started on TPN is exhibiting signs of thirst and increased urine output. What would be your first nursing action? Who said? Somebody said it.
Stop.
No, not stop. Check a blood sugar, right? Because how am I going to tell if that's symptoms from just they're sweating because it's hot in the room? I sweat like a beast. Or are they, but I'm not hyperglycemic, or are they sweating because they're truly hyperglycemic? How am I going to know as the nurse? I'm going to check that blood sugar. Can they get hypoglycemic? Sure. What happens if my bag runs out? I've been giving sugar, and then my bag runs out. Or the patient, because of a mechanical problem, rips it out. Or, yes. I'm sorry, what? Oh, you got it. You got it? Okay. So, now my patient who is on, we only get one bag a day, right? Because the physician rounded in the morning, the pharmacist made it up, it's super expensive. I had it hanging, my patient forgot they had it, got up to go to the bathroom and ripped it out of their arm. Can I reuse this bag? It's aseptic, right? It's laying on the floor, it's just been exposed, so now I can't use this bag. And I've had a patient who's been getting glucose this whole time. What do I maybe need to do? Hang some D10. Good job. You're going to make sure that you're going to give them some dextrose or something to stabilize them so that they don't get hypoglycemic. They can get a fat emboli. What are some clinical manifestations? They get short of breath. They can have allergic reactions, which we've talked about. They can get infection. What are some signs and symptoms of infection? Yeah, fever. So they start developing signs of an infection. What do? I can stop it, but how do I know that that fever's from that? It could be. I could get a culture? I could. Yeah, I could see what's going on. I want to see what's happening with this patient. Hyperlipidemia. So we're given fats, right? What happens when we give too much? If we give fats too quickly, too fast, they can get nauseous. They can develop a fever. They can develop refeeding syndrome. So we have to really monitor our patients, right? This is not just pharmacy sent me this bag and I'm hanging it up. I'm monitoring these signs and symptoms, and when I'm seeing them, I'm running that differential through my head. A fever doesn't mean a reaction. It doesn't mean that they're getting, have an infection, but could it? Heck yeah. So what are things that I need to do as the nurse to make sure I rule this out? All right, so we've talked about some of this. Before administering, check the label. Examine the bag for any signs of contamination. Again, this is all aseptic. This is going into a central line. Confirm placement. So if you're giving through a central catheter, and again, we're going to get to this. You want to make sure that it's actually in the SVC, right? You don't want to just start giving a bunch of stuff and not know that it's not in the right place. So how do we know that this is in the right place?
X-ray.
I was going to say it's out there. Yeah, just X-ray.
Dr. Dan,
Yeah.
I've actually had a couple
I'm going to say for our purposes, you need to verify through chest x-ray. Different hospitals may have different policies. And I mean, yes, you can cause a dysrhythmia by doing it, but that's not best practice how we're going to teach.
I mean, I was just wondering if that's something that should be worried about. Or is that actually an accepted method?
I can't speak for or against that.
Okay.
All right, vital signs every 4 to 8 hours. Daily weights. Obviously, we're going to do blood sugars like we talked about to worry about hyper or hypoglycemia. Check electrolytes. We use a filter with TPN. And we have to be careful because the lipids, which are really fat or thick, oh my God, I'm so sorry. The lipids are really thick and fat. We do not want these. Is there a filter? Is this the filter? Yeah, it doesn't really look like this. I think this is what they mean by filter. It's a little bit like rounder, thicker. But you would hang your lipids and you would put them below the filter and your TPN above the filter. I don't have enough hands to make it. Oh, there we go. We monitor for any signs and symptoms of infection, like we talked about. You guys already did it. Blood culture, sterile dressing changes, and patient teaching. Yes.
Is the difference between, I'm just a little confused. There's one that nutrition brings and then there's one the pharmacy brings, right? As far as like food